Hi everybody, it's Adam with HeartValveSurgery.com, and this is a very special video about shared decision-making between patients and their surgeons. I am thrilled to be joined by Dr. Eric Roselli, who is the Chief of Adult Cardiac Surgery at the Cleveland Clinic in Cleveland, Ohio. During his extraordinary career, Dr. Roselli has performed thousands of heart valve repair and heart valve replacement procedures. We are also joined today by a two-time heart valve surgery patient, Ari Mintzer from Chicago, Illinois, who is one of Dr. Roselli's patients. Dr. Roselli, it is great to see you again. Thanks for being on the line.
Hi, Adam. Always great to see you too, man.
Yeah, and we also have with us Ari Mintzer. Ari, thanks for being with us today.
Thanks for having me.
Yeah, so we're going to get into this topic of shared decision-making. But first, I understand, Ari and Dr. Roselli, that you two have a little bit of a history together. Ari, maybe you can share with all the viewers how you first came across the name Eric Roselli.
Sure. So I was at the University of Michigan back in 1992, pledging Sigma Alpha Mu fraternity. And Eric at that time was a senior. We actually first met on the intramurals football field. So known him ever since.
I guess you'd say a little cherry on the top is that I was very fortunate to be in Ann Arbor at the University of Michigan at the same time as the two of you. So this really is a wonderful reunion of sorts, except we're not talking about Michigan football. We're talking about heart valve surgery. And let's get into that, Ari. For the patients who maybe don't know your story, can you share a little bit about your history? What were you diagnosed with and what was your original treatment?
Sure. So I was born with a congenital heart defect. My aortic valve was bicuspid as opposed to tricuspid. Aortic stenosis and insufficiency was the way they described it to me. And I was monitored that for the better part of my first 30 some odd years of living. But about 15 years ago, it was time to get the valve replaced. And so I had a surgical aortic valve replacement with a cow tissue valve and an aneurysm repair. I had done that here locally in Chicago.
So Ari, you had the initial TAVR, aortic valve replacement. Can you talk about how that worked for you?
Once you get past that initial phase of getting out of the battle of the open heart surgery, everything was unbelievable. I mean, I felt like I'd never felt before. Like I had an extra kind of breath to me. I could, run long distances without, being extremely fatigued. Any sport I wanted to play, there really were no limitations. Whereas previous to the surgery, I was constantly getting winded and reminded of the fact that I had, a medical condition.
All right, it's great to hear about that result. And how long did that continue for?
The good times lasted for probably about a decade. And then, give or take around 10 years, I started to feel myself getting a little bit more tired with the same level of activity. And I kind of chalked it up to just aging as opposed to anything wrong with the valve. So I would say probably I said 10, probably like 12 years, I felt pretty good. And again, didn't even think about the fact that I was going to have my valve replaced once again.
And then came the news, right? I'm guessing you're feeling some fatigue, out of breath. You go see a doctor, have an echo, and what did you learn?
Sure enough, the valve that had been replaced, its time had come. And so then the decision process began as, okay, now what do we do?
Dr. Roselli, you see a lot of patients, thousands of patients at the Cleveland Clinic. Is the scenario that Ari just shared with us common?
Yeah, absolutely. We know that close to 2% of the population is born with an abnormal aortic valve. They get sort of broadly categorized as bicuspid aortic valve, but there's a real spectrum of sort of how that congenital abnormality presents in different people. We have patients that range from infancy to their 80s. A lot of patients have aneurysm associated with the valve dysfunction. Some of the valves leak, some of the valves are stenotic. So there's a whole bunch of details about the disease that are important to understand.
Ari, it's obvious you got in touch with Dr. Roselli to help you out, but I'm curious, why specifically did you want to hear from Eric about his thoughts on your valvular condition?
First and foremost, you want to go with people that you know and you trust. And so that was the obvious connection there. Not to mention that Eric is, one of the top performers at one of the top places in the world. So it just seemed this is who you want to speak to. Eric was very clear on, you've got lots of different options to choose from these days. And so we kind of just walked through all those potential options at that time. At that point, it was time to do my homework and to really go out there and kind of pursue those different avenues and figure out what's going to be the best solution for me, given my lifestyle, given my age, given what I want to accomplish in this lifetime. What is going to make the most sense? And it was great to have Eric as that initial sounding board to kind of present me with all the various different options that were out there.
So Eric, you get the phone call from Ari, known him for 30 years.
Yeah.
I'm curious to know what, from a surgeon perspective, when you hear him talk about his aortic valve, it's failing, the aneurysm that was already replaced, where does your mind go in terms of how you might be able to help him?
We consider it a privilege when people ask for our help. So when it's a friend that I've known, Ari has known me before I was Dr. Roselli, calls and asks my advice about something, I'm like, this is the best thing ever. I've got a friend that's asking me about help and it's in my wheelhouse, So I guess that's the first thing I'm thinking. I think I was driving in my car when we were talking about this the first time around, Ari. And I told you, I'm going to tell you because you're my friend, like the straight thing. But then after I said that, I thought I'm always this way with my patients because it's not an easy decision. It's never an easy decision about sort of what to do and how to do it. But it's also kind of, it's scary when you're in this situation and you have all these choices to make, but it sure is nice to be able to sit down and think through it versus being, swooped up on a helicopter and brought somewhere where you have to have something done in an emergency.
Ari, Eric, this is just an open question for you both. Maybe we start with Ari. It's 2022. It's not 1962. And there are options for aortic valve reoperations all over the place. I'm curious to know, what was your thought process? What did you consider? And ultimately, what did you guys choose together?
Yeah, for me, the decision came down to, did I want to be looking at a mechanical valve? That was a quick no. The idea of being on a blood thinner for the rest of my life, having to worry about some of the ticking that goes along that I heard about, the potential for aneurysms and strokes, it was just too much for me. I have a very active lifestyle. I have 3 boys, 2 dogs, and a wife, and we like to be outdoors and we like to be playing sports and running around and doing stuff. And that was not a viable option. The second option I considered was the TAVR. There were great things about that I heard about. You're in and out within a day. Everything's great, right? You don't have to have your chest cracked open. There's a lot of benefits, right? The problem was my age demographic. There wasn't a lot of history. There still isn't a lot of history and data on longevity. I then looked into the Ross procedure, and Eric and I talked about that at great length along with the others. And I was kind of dead set on going with the Ross procedure for a period of time. And it just was one of those things where at the end of the day, there was a potential risk of creating another valve problem on the pulmonary side down the road. And I just felt like, for me, that was too big of a risk. And so I had surgical aortic valve replacement with another cow tissue valve. And we were going to do a bigger valve this time so that we could, down the road, do another valve within valve. And so that was it.
From your perspective, Eric, what were you thinking when it came time for that surgical aortic valve replacement?
Ari said it very well. The valve-in-valve option at this point, although we know it can be performed pretty safely, it's really unclear how durable that is. And so for somebody who we know is going to outlive another biologic valve, whether it's TAVR or SAVR, I trust the surgical valve better because I have good data. That technology has been pretty stable in the design dating back to the 80s. So we have, decades of follow-up data on thousands of patients. Ross, I do Ross procedures. I'm a little stricter about who I do Ross procedures in my experience, it is younger patients, typically 40 or younger, sometimes in their 40s. But in Ari's particular situation, he's already had his root and his ascending aorta replaced. And the reason was in his 30s that he already had evidence of aortopathy or aneurysm of his aorta. And when you're born and when you're developing in utero, the cells that become your aorta also are the same cells that become your pulmonary artery. And if we take that pulmonary artery and put it in the aortic position under those sort of load conditions on the left side of the heart, there's a risk that Ross could fail by causing an aneurysm in you. And so it didn't make sense to do a Ross as a redo in a guy who had a history of aortopathy, whose valve was degenerated. Made more sense just to get you a new valve. And so I thought that a lot of our discussions should sort of focus on mechanical versus biologic.
Eric, great learning all of this information, which I didn't know. And Ari, thank you for walking us through how you went about the steps to choose the surgical aortic valve re-replacement. And one thing that I got from hearing you two talk is this decision-making process. And in cardiac surgery right now, the idea of shared decision-making is big among patients and their medical teams. And to start, Eric, can you maybe help the patients understand exactly what is shared decision-making?
It's kind of a buzzword topic these days, shared decision making, and I'm glad because in the current world of healthcare, where you have really a really broad spectrum of decisions to make, which is nice, but also can be very confusing. Talking about this concept of shared decision making sort of forces us to slow down and make sure that we're doing exactly that. You know, a couple of generations ago, physicians were, very paternalistic. In fact, in the end of the 1800s, it was considered, ethically wrong for a patient to not listen to their doctor. We don't live in that kind of world now. And it's great that we don't, because there's knowledge everywhere for everybody. And so I love it when a patient comes in with one of those yellow legal pads full of questions. Bring it. Let's talk about it. Let's make sure that, all the knowledge that you're getting is being interpreted well and being brought into the very specific personalized perspective of your issue. And that's where your doctor can help you, because you're going to get information from a whole bunch of different places. Even physicians have these guidelines, documents. It's a guideline for any individual patient. Your decisions should be personal. They should be tailored to all of your medical specifics and your personal desires, as well as the expertise that the physician you're working with. And to me, that's what shared decision-making means. And I think everybody does better when we embrace this concept.
Dr. Roselli, I loved hearing your explanation and description of shared decision-making. And I also loved hearing about those patients who are coming in with all of those notes on that yellow legal pad saying, let's figure this out together. And I'm curious to know, when you think about the lifetime management of valve disease for your patients today versus 15 years ago, is this conversation more warranted because we're living life longer? We're learning that perhaps early surgery for things like valvular disease is a good thing, not a bad thing. Can you talk about the lifetime management and how that might correlate to shared decision-making?
No, I love that. And I teach all my residents and med students and fellows and everything else, like even when we do research projects, let's not focus on the thing that we're doing, the procedure we're offering. Let's focus on the disease that we're treating. Start from sort of that base and give it that broad view, because it's a fast moving train. This is a moving target of all the sort of objectives that we want now. May be different than they were 5 or 10 years ago. The tools in the box have changed. So we have to appreciate that. and do the best we can to look down the road. So for example, in the valve space, if I'm going to put a bioprosthesis in a young guy like Ari Mintzer, who's going to outlive that valve, maybe outlive a couple of them, I'm going to make sure it's big enough that it not only is very efficient and can allow him to exercise and do all the things he wants to do, it's also going to be efficient, which might translate to it being more durable, which is pretty cool. And also, it's going to be big enough to house a TAVR valve in the future as that technology evolves and we gather more data in the next decade and understand that that might be a real option for them. I also make sure the little details like how I sew that valve in, that if I have to come back and operate again, it'll be easy for me to cut it out in such a way that I can drop another one in without having to take the whole aorta all apart. So there's all those little details that we keep in mind with that broad view of lifelong care.
Eric, loved hearing that. And going right over to Ari, when you were going through this decision-making process, you and I had several great calls talking about what was available to you. And I remember one of the first things you said to me was, Adam, I just want to figure out a way to get to 90. And in my head, I kind of struggled with how we were going to do that, because at the time you were thinking about TAVR. And I was kind of, I don't know, but I'm curious to know, given all of this discussion about your options, all of the physicians you talked with, talking with Dr. Roselli, do you feel like the shared decision-making approach has got you to that path to reach 90?
Absolutely. Yeah, no, it's funny because I go back in my head too, and Eric and I talked about it extensively too, was if you did this and then that and then the other, this would get you to like 80. Or if you did it this way, that way, the other, this could get you to 75 before you have to have a reoperation. And so you kind of we went through all the math and all the numbers, and then, that was just kind of out there in terms of, okay, we know there's going to be something else down the road. But what is the most viable path to 90? And Eric, since has focused me on 100, which is great.
So Ari, you have no doubt been through a lot when it comes to your heart valves, the aorta replacement. And I imagine patients are really enjoying this conversation, and they might be wondering, what advice might you have for someone who is in maybe a similar situation, or maybe is in just a different valvular condition, maybe something with their mitral valve? What advice would you have for them about developing kind of a shared decision-making approach with your medical team?
It starts with knowledge. Yeah, I know it's cliche, knowledge is power, but it really is. And especially in this world where, look, I have to imagine most of us who are heading into this, we have a different day job, right? We're not in the medical field. So while it's probably a small deal for something, even an open heart surgery for Eric to perform, because he does it every day, for the patient, it's a big deal. And so, like anything, for me at least, and what I would recommend to everyone is just go. There's a significant amount of information out there, different resources, whether it's online or books or anecdotally or, other patients, right? Just to get as much information and knowledge as possible so that you can ask the right questions, because a lot of times you don't know what you don't know. And so if you just kind of go out there and be a sponge, act like as if you're a sponge, take in everything, appreciate how it relates to you, and then really make your the yellow notepad you talked about earlier, really write everything down. And so that you can walk into a doctor's office or give a call to Eric and say, hey, these are the questions that I have. These are the options I'm thinking about. What am I missing? What are the benefits? What are the risks? And really going through that process. I think it's critical having that knowledge.
And Ari, I got to give you a lot of credit, because I remember how hard you went at this, trying to learn as much as you can. And now let's flip it over to Eric from the surgeon's perspective, right? It's one thing to say, let's go do our research. Let's go figure out what we think is right. But when we get into that office and maybe the patients are a little nervous, or they have white coat anxiety, what advice would you have for patients? Or maybe what do you do to help a patient feel like they can be part of the shared decision-making process?
Yeah, look, you said knowledge is power. And the reason is because fear comes from the unknown. And I have seen this over and over again where, I meet with a patient and I can tell, sometimes they don't know how to ask the right questions, but I can tell they don't understand the situation. And I think it's our responsibility to make sure that when we leave that office, the patient understands enough that they feel comfortable with the decisions they made. Sometimes it means drawing a picture or finding some way to sort of communicate with them and make sure that their questions are answered. We pay a lot of attention to that in the medical field to make sure that we're good about addressing that, because people come with all different kinds of backgrounds and knowledge and communicate in different ways. And I'll tell you, it's always satisfying to me when someone comes in, I can tell they're afraid, and we get to a point of knowledge or at least comfort with a decision, and I can see like the furrow in their brow relaxes and they're at ease. And even if it's a bad situation or a tough situation, people are courageous and they can handle it. And I think that's important for us to make sure that we're addressing it that way.
Ari and Eric, loved hearing about your views on shared decision-making. And really what I heard from both of you is what I really hope patients can embrace, which is, Ari, the knowledge is power. That's the education. And Eric, I love how you really take a patient-specific view for tailoring their treatments and empowering them to ask the questions they need answered, not just for the now, but thinking about what might happen given the nature of valve disease over their lifetime. So on behalf of all the patients at HeartValveSurgery.com, anybody watching this video, I want to thank you for being with me today and sharing your thoughts on shared decision-making. Thanks for being here.
Thanks. And first and foremost, thanks to Eric for all he's done for me. Don't have enough words out there, but thanks for everything. And Adam, thanks for all that you're doing for the heart valve community. Really greatly appreciated by, I'm sure, everyone around the world.
Thanks for putting your trust in us, Ari. Keep up the good work, man. And you too, Adam. Thanks for the opportunity to empower patients. Really great discussion today, guys. Thanks.
Hi, everybody, it's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel, watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.